This is Clinical Conversations. I'm Joe Elia, and my co-host, Dr. Danielle Schurer of the Medical University of South Carolina, is on the line. Hi, Danielle.
Hi.
So here we are. This is our 150th. So, and it's the conversation's about a stroke report that's measuring the prevalence of depression after stroke and TIA in a U.S. cohort, as well as its relative undertreatment. Our guest is Dr. Nada El-Husseini, the article's lead author. Dr. El-Husseini is a cerebrovascular disease fellow at Duke University Medical Center in Durham, North Carolina. Welcome, Dr. El-Husseini.
Thank you.
Glad to be here. Thanks. You followed over 1,800 people to determine the prevalence of depression, both right after cerebrovascular events and in the longer one-year term. Can you sort of give us a just general overview of what you found?
Sure. So we found that the prevalence of depression after stroke was similar to the prevalence of depression after TIA. The prevalence of depression was 17.9% at 3 months versus 14.3% in the TIA group.
Mm-hmm.
At 12 months, the prevalence of depression in the stroke cohort was 16.4% as compared to 12.8% in the TIA group, and that difference was not statistically different.
Mm-hmm.
Mm-hmm. That was one finding, and it's among the few studies, or maybe even the first study that compares these two groups together. The other things that we also compared the rate of antidepressant use, and that was similar among the two groups.
Mm-hmm.
We looked at the percentage of patients who had persistent depression, meaning depression at both 3 and 12 months follow-up, who were not getting antidepressants,
mm-hmm.
and found that about 70% of these patients, whether they had stroke or TIA, were not using any antidepressant,
mm-hmm.
suggesting that these patients are undertreated.
Okay.
So that was the second most important finding of that study.
All right.
And you also found a number of factors that were associated with persistent depression, again, which you defined as both 3 and 12-month follow-up. And some of these factors just sort of make common sense, meaning, the patients who had events at younger age or had higher disability scores. Were there any other things that you found that surprised you as far as what predicted whether or not they did or did not have depression?
No, I mean, the predictors of those who had depression among stroke patients
mm-hmm.
Were not really surprising. They included, as you suggested, younger age, those who had greater stroke-related disability, and those who are unable to work at 3 months.
Mm-hmm. Mm-hmm.
So it's not very surprising. It just indicates that these patients we need to be more hypervigilant in screening them
mm-hmm.
because they are at higher risk for persistent depression. I think younger age has been mentioned before, but some people or clinicians don't expect that if you are younger, you're going to be more depressed.
Mm-hmm. Mm-hmm.
But I think that's an important thing to consider.
And you also, as you mentioned, almost two-thirds of the patients with depression, there was no evidence that they were receiving an antidepressant, which is a pretty surprisingly high statistic. What do you think is going on there? Why do you think we're significantly undertreating those who meet clinical criteria for depression? Do you think it's that we're not screening, or we screen them in, yet they are reticent
of course,
to take
that
it?
study was not set to study that in particular. However, it is possible that we're not screening enough because there are no absolute clear guidelines about when to screen and who should screen for depression after stroke or TIA.
Right.
So I think there is more work to be done in the future to set these goals and to determine that screening for depression is essential given the high rate of depression that we find after both of these conditions. So I think that would be helpful. The other message out of this study is, again, applies to clinicians, as we said, but also to patients themselves, because once patients and the general public is more aware of this correlation, then they would probably be more prone to bring their feelings up during their clinical encounter with their physicians and mention it as another symptom. I think better treatment results would be obtained like that.
Well, I wanted to ask to explore a little bit about the communication between the neurologist and the primary care clinician after the event. Is it possible that there's miscommunication there that could be improved?
I think it is possible. In this study, I mean, we didn't have enough numbers to look at these correlations. We did a univariate analysis, meaning that we looked at each variable alone, and we looked whether patients saw a primary care physician in the interim to see whether even seeing a physician during that year after stroke would obviously improve the rate of depression being detected. But because the numbers weren't big enough, we didn't see any factor that specifically correlated with those who didn't get treatment versus those who did. So from this study alone, I don't think we can tell for sure what are the factors that dictate whether who gets better detection, who gets treated for depression.
Okay, fair enough. You recommend screening for depression through the first year after the event. So, and in your paper, you say that you know your evidence refutes the mistaken hypothesis that it's only the first few months that the patient is at increased risk for stroke. So, what might clinicians do differently to deal with this problem that, say, next week that they haven't been doing?
Well, I think it's important to know that both stroke and depression are chronic illnesses. And once you have a stroke, I think you're at a high risk for having depression, whether it's the result of the stroke or just the association with the comorbidities or the result of the brain injury. So that correlation, I don't think, goes away. Again, that study was only extended to 1 year. However, there are other studies that suggest that the rate of depression continues to be higher even beyond the year, as well as other studies that suggest that depression puts you at high risk for having stroke. So I think the two are interrelated and very frequently comorbid. So I think the message would be that if you have a stroke patient that you're treating, it would be worth at least screening for depression during the clinical encounters. And even with simple questions and more simple scales are being derived to try to do this in an efficient manner. And there are also several studies that show that improving depression or treating it do improve stroke outcomes. So I think this is the message, that the two are comorbid and we need to be screening more for depression in this population. It's not only among stroke, but also among those who have TIAs. And this is the other important message, that those with TIAs don't have disability usually resulting from their TIA. However, they still have a higher rate of depression than the general population.
Right, so that probably is the population that would be more likely to be missed with screening. In other words, if you see a patient months out from their stroke and they have a residual disability, it seems like you would be more likely to do a depression screening as opposed to if they have no residual disability. There's no, obvious reminder to say, oh yeah, they have to remember that they had a TIA 6 months ago that will increase their risk for screening in for depression.
Yeah, I think that's a great point.
I wanted to thank you for joining us.
Oh, thank you. Thank you so much.
Excellent. All right, take care.
Thank you.
Thanks.
That was our 150th edition. All the earlier ones can be found at podcasts.jwatch.org. Well, we come to you from Journal Watch, whose website is jwatch.org. Clinical Conversations executive producer is Adoriano. I'm Joe Elia. Dr. Danielle Schurer and I thank you for listening. Join us next time.